Hello. Hi, good evening, friends. A warm welcome on behalf of MIDAS Medical Foundation and Multi Speciality Hospital. Today, we have a 108th clinical meeting, which is basically theme based mainly on the pancreas. Last month was a pancreas, I think, pancreas awareness program. So we didn't have the turn to have a clinical meeting last month. So we decided to have the clinical meeting this month with the theme of pancreas. We'll be presenting some interesting clinical problems in this clinical meeting. May I request Dr. Abhiram Paranjape, Dr. Nikhil Khobragade, Dr. Yogesh Vaikar, Rajvilas Narkhede informs me that his grandfather is not well, so he expressed his inability to join. He is to rush to outstation. And Dr. Manpreet Uppal, a GI surgeon from All India Institute of Medical Sciences, is held in some emergency and she will be joining late. And I take this pleasure to welcome our senior faculty members online, Dr. Jayanthi, who is a consultant gastroenterologist at Chennai, and Manu Tandan, who is uh, one of the senior gastroenterologists at the prestigious AIG Hyderabad. With this brief introduction, I'll hand over the mic to Chairpersons. Thank you.
Good evening, everybody. It's a single topic CME today, and we know the cases would be not simple. There will be a lot of diagnostic and treatment dilemmas. We are lucky to have Dr. Manu Tandan and Dr. Jayanti Madam to guide us in difficult situations, to discuss the difficult situations today. So we straightforward begin with the cases. The first case is to be presented by our GI surgeon, Dr. Yogesh Bang. It's a case of pancreatitis with gastric outlet obstruction.
So, good evening, everyone. Can we show? Yeah. So, I will be presenting this interesting case of a chronic pancreatitis with gastric outlet obstruction. This is a case of a 31-year-old male who is alcoholic. He had a past history of suffering from necrotizing pancreatitis in 2016. May 2016, he had the episode of alcohol-induced necrotizing pancreatitis. He needed a necrosectomy in that time, like 6 years back in May 2016. He recovered well from that episode. And in August 2016, patient had a history of gastric outlet obstruction and endoscopy was suggestive of a benign D1, D2 stricture for which an endoscopic balloon dilatation was done. Now 2016 August to 2022, this period of 6 years, patient was absolutely asymptomatic. But one thing, that patient started alcohol again 2 years back. So in 2020, patient started drinking alcohol again. And in May 2022, patient had history of vomiting, which was non-bilious. There was no abdominal pain. For this, the patient was evaluated at Hyderabad AIG, and endoscopic ultrasound and endoscopy was done, which was suggestive of a benign gastric outlet obstruction. There was edematous duodenum, and EUS was suggestive of bulky head with calcifications. The biopsy from the biopsy from duodenum was just non-specific duodenitis. So, considering some acute episode of pancreatitis causing this gastric outlet obstruction, a nasojejunal tube was placed, and after 3 months, patient improved completely, and this nasojejunal tube was removed after 3 to 4 weeks. Sorry. So from May to July 2022, patient again was asymptomatic, and then patient came to us with non-bilious vomiting in July 2022. There was no jaundice, there was no pain. This time again, history of alcohol intake was there. So a Riles tube was kept, stomach washes were given, and then we did an endoscopy. The endoscopy, as you can see here, as the endoscopist is trying to enter the duodenum, the mucosal edema of duodenum was actually bulging into the pylorus, into the stomach, and there was, with a great difficulty, the endoscopist could enter the duodenum. So again, this was a benign gastric outlet obstruction or a duodenal edema. You can see the lateral wall of duodenal, the folds are absolutely normal, and the medial wall is showing edematous duodenum or the mucosa which is inflamed and edematous. So again, a biopsy was taken from this, and it was suggestive of duodenitis. And during this episode, considering it was an acute episode with duodenal edema, a nasojejunal tube was placed. The endoscopic biopsy was suggestive of chronic duodenitis. Sorry. Yeah. So with this, patient was discharged July. Patient was placed on NJ and was discharged. Patient over a period of 1 month continued to have NJ feeds and then started eating on his own, and he was asymptomatic. He came to us back in September 2022. He was eating very well and was taking liquid soft diet also. NJ was still in situ. There was no vomiting, no jaundice, no pain. Alcohol intake was stopped. CA19 was normal. His liver function test had started showing decrease in the alkaline phosphatase. And as we went in again this time, you can see that duodenal edema or the mucosal fold edema which was there in D1, D2 had significantly decreased. So at this episode, considering that the patient had a complete symptomatic relief with abstinence of alcohol, and as the acute episode of pancreatitis resolved, we removed the NJ and asked the patient to be abstinent and continue regular follow-ups. So as we enter the duodenum here, you will be seeing the edema which was comparatively less as compared to the endoscopy which was done in July. Even the entering into the D1, D2 was a bit easier in this endoscopy as compared to the one which was done in July. So looking at this, the NJ was removed and patient was discharged. But within a month, patient came back to us with vomiting. The most important thing in this whole presentation from May in Asian to October 2022, this 6 months, to us, patient never had pain. Patient always had vomiting. There was no jaundice. With continued vomiting, this time patient had weight loss also, and there is no alcohol intake in this past 6 months. So this endoscopy, you can see how much the edema or how much the bulkiness that duodenal fold had, and the mucosa in the duodenum was completely edematous and red. These are the stomach. As we entered, we could see the food residue in the stomach. And as soon as you look at the pylorus, you can see the red, inflamed or the angry looking duodenal mucosa coming into the stomach, prolapsing into the stomach. That much bulky. See, that is the duodenal edema which is coming into the stomach, and that much was the extent of problem which the patient had. Now within a 1 month, without even alcohol intake, patient again had gastric outlet obstruction and vomiting was recurrent. So a surgical consult was taken. As I entered the picture, I asked for a CT scan. And if you look at the CT scan carefully, you can see a grossly distended stomach here, calcifications in the head, and this was a gross edema in the head of pancreas, which we can see. Okay. So in the contrast phase also, we could see inflamed pancreatic head, dilated pancreatic duct, and there were some cystic lesions in the pancreas and duodenal groove, probably the pseudocysts or intrapancreatic or intraduodenal pseudocysts related to recurrent pancreatitis. So a distended stomach. And as we come here, this was the inflamed, completely inflamed duodenal and pancreatic area, head area. And that was the reason why patient was having recurrent gastric outlet obstruction. Even in venous phase, we can appreciate that very well. So based on this, we advised the patient that he should undergo gastrojejunostomy. The other important finding in the CT was dilated IHBR. Both the right and left duct and intrahepatic ducts were dilated. CBD was dilated and patient had alkaline phosphatase which was raised. But there is no pain. So I advised the patient to undergo gastrojejunostomy and a biliary diversion. We also did an endoscopic ultrasound just to be sure that we are not missing any malignancy. Saurabh will comment on this. So,
Hi, good evening. Yes. So this patient, we did endoscopic ultrasound, and as you can see, the upper endoscope, it's very hard to get it across into the second part of the duodenum. Echo endoscope, which is the EUS scope, is bulkier, so it is more difficult to put it into second part of the duodenum. So the most we could advance it was a duodenal bulb. Beyond that, it could not be advanced safely. So what we, this is I guess a fairly long video here, but, oh, you've edited it, okay. So what you can see is a lot of calcifications are visible. I know most of you are not familiar with the black and white images, but what we could see are several calcifications. There were cystic areas. The duodenal wall was not convincing evidence to suggest sort of cystic lesions in the duodenal wall between the groove between the pancreas and the duodenum. But again, we were not visualizing the entire area in this case. So to my eyes, it looked like a patient with chronic pancreatitis with a lot of inflammation and some intrapancreatic cystic spaces, which is what we could visualize from the duodenal bulb.
Thank you, Saurabh. So one thing which we wanted to rule out was malignancy. Of course, in such a young age, it's usually not seen, but still, before going in for surgery, we wanted to rule that out. On endoscopic ultrasound also, we couldn't see any pancreatic head mass. CA19-9 was still within normal range, 2022. So this patient had a chronic calcific pancreatitis, surprisingly no pain. Patient had gastric outlet obstruction, which is recurrent. Patient has a dilated CBD and intrahepatic bile duct, which are dilated, and raised alkaline phosphatase, CA19-9, which is normal. Pancreatic duct is dilated in head, body, and tail, it's normal. There is no diabetes, there is no pancreatic enzyme insufficiency. So we made the diagnosis of chronic calcific pancreatitis, ethanol related with gastric outlet obstruction because of the inflamed duodenum or duodenal edema with distal CBD stricture, no cholangitis. Considering the symptom only of gastric outlet obstruction and a dilated CBD with raised alkaline phosphatase, we planned for laparotomy with gastrojejunostomy and a choledochojejunostomy as a biliary drainage procedure for this patient. I'm sorry for that I don't have intraoperative pictures of the patient surgery, but this is what we did. This is a loop gastrojejunostomy which we did. A roux limb was taken up to the bile duct. Biliary anastomosis was done there, choledochojejunostomy, and distally we continued the enteric continuity with the jejunostomy. So after the surgery, patient recovered well. There is no vomiting right now, and patient has actually started gaining weight. Even his alkaline phosphatase has come down to normal. This surgery was done for 2 months back, but it's right now comfortable. So coming to complications of chronic pancreatitis, this is a common picture which we see. We can get each and everything in patients like a dilated pancreatic duct with stones, sometimes pseudocyst. The pseudocyst may also rupture. The duodenal head edema might cause distal CBD stricture, or even it might cause the compression on the duodenum leading to duodenal blockage, or even there can be portal vein or SMV thrombosis. So we were dealing basically with the head area, and intense inflammation in the head was causing the compression in the duodenum or the duodenal edema, and there was a dilated bile duct. So when we look into the incidence of complications of chronic pancreatitis, as we all know, majority of the patients have pain. Our patient didn't have the pain, and a bile duct, duodenal or gastric obstruction is seen in nearly 5 to 10% of patients. So when we thought over this patient, is it a paraduodenal pancreatitis or a groove pancreatitis? This is something was also going in our mind. So what is paraduodenal pancreatitis? It's a form of a chronic or a recurrent focal pancreatitis limited to head or groove of pancreas and duodenum. It affects the gastroduodenal groove, specifically in this area, which is the area between dorsocranial portion of pancreatic head, duodenum, and CBD. Why we feel it could be groove? If you look at the CT individually now in this pic, so this is the contrast filled duodenum. This is the head of pancreas with this dilated pancreatic duct, and in between these two, you can see that the grayish colored groove. Okay, so this was the groove of pancreatitis, which was very much thickened, and that is how a groove pancreatitis looks like. A pure groove looks like that. Our patient had, of course, some cystic lesion in head, pseudocyst, and calcifications. Again, here you can see the cystic lesion just next to the wall of duodenum. These are the cystic lesions in the wall of duodenum, which can be very well seen. These are the pseudocysts, and again, this is small cystic lesion in the wall of duodenum, which is characteristic of groove, as you can see there. So that's why we kept one of the differential as paraduodenal pancreatitis. These are various names or terminology with which the paraduodenal pancreatitis is known, that is cystic dystrophy of heteropic pancreas, groove pancreatitis, paraduodenal wall cyst, or pancreatic hamartoma of duodenum. It is known to be caused because of chronic alcohol consumption which our patient had. Basically, it's the functional or anatomical obstruction at minor papilla, and then the secretions of this minor papilla enter into this groove because of the obstruction, and they lead to inflammation in this area causing the groove pancreatitis. When we look into the variants, there is a solid variant or a cystic variant. Solid variant is basically a solid mass forming predominantly in and around the minor papilla. This is classical to be known as groove pancreatitis, which is either a pure form. Pure form is something in which only the groove of duodenum and pancreas is involved, that is only showing the thickening. Rest of the pancreas, head and body and tail are absolutely normal. There is no calcification, no dilated PD or anything. Or a segmental form in which along with the groove there can be involvement of head leading to dilated pancreatic duct. Or there is other paraduodenal pancreatitis, that is cystic variants, the cysts with or without inflammation, thickening or fibrosis of duodenum. These cysts could be intramural cysts in the duodenum, or this cyst could be in the pancreatico-duodenal groove, also known as paraduodenal cysts. The best way to look after these cysts is an endoscopic ultrasound through which you can enter the D1, D2 area and look at the duodenal wall, whether the cysts are just next to the submucosal layer or are outside into the groove. And taking a FNA or biopsy from that can give us a diagnosis of groove pancreatitis very well. Now, how it happens? It is basically 2 or 3 mechanisms which are being described, either anatomic disruption of minor duct, pancreatic heteropia in the duodenal wall, ectopic pancreas tissue in the duodenal wall, chronic alcohol intake, or as I said, incompetent minor papilla. All these things sometimes combine together, leading to, because of chronic alcohol intake and all, leads to pancreatic fluid viscosity which gets increased. That pancreatic juice gets leaks into the groove, accumulates there and leads to formation of pseudocyst or inflammation there, causing all these things. So can our patient fit into this? Our patient was a chronic alcoholic. He had gastric outlet obstruction. Patient had duodenal inflammation and edema. Retrospectively, when I look at the CT very carefully, I can say that cystic lesions were there in the paraduodenal area and pancreas, and patient also had distal CBD obstruction. But one of the most important presenting feature of a groove or a paraduodenal pancreatitis is pain, which is seen in 90 to 95% of the patients. Surprisingly, our patient didn't had any. Calcifications in head in our patients were significant. In groove, you can get those, but these are very small or punctate calcification. And our patient also had a dilated PD in the head, which can go in form of a segmental groove, not a pure groove. So what exactly it is, I will still say it's a chronic pancreatitis with recurrent inflammation causing duodenal edema. I'm not very much sure whether we can call it paraduodenal pancreatitis or not. I'll leave up to my panelists to say me yes or no on that. Whether this patient needed any drainage procedure or phrase, no, of course not, because patient didn't have any pain. And why there is no pain, I still don't have answer for that. Thank you.
Thank you, Yogesh. Do you mean to say groove pancreatitis is a different etiologic entity? It's separate from alcoholic pancreatitis? Or any etiology of pancreatitis can present as a groove pancreatitis?
Sir, alcohol is the predominant cause of groove pancreatitis. In the etiopathogenesis of groove pancreatitis, if you look at it, alcohol is the predominant cause by which it can happen. Of course, as you are asking whether both are different, both are different in the sense rest of the pancreas is absolutely normal in groove. It's only the pancreatico-duodenal area or sometimes head which is involved. Body and tail are totally normal in groove pancreatitis. The patients of groove pancreatitis seldom land up with pancreatic enzyme insufficiency. Groove is a type of chronic panc, but they seldom land up with pancreatic enzyme insufficiency or diabetes mellitus, because it's a focal area of the head which is involved in groove. But etiology is still alcohol for this patient.
Respected Jayanthi Madam and Manu Tandan sir, we would like to know more from you if you can have.
Jayanthi, you are telling something.
Yeah, did the patient have jaundice? You mentioned about the...
Ma'am, alkaline phosphatase was raised, jaundice was not there.
Jaundice, is it possible that we're still missing malignancy and you could have gone for a witness? I was just wondering.
Ma'am,
Yeah.
so CA 19.9 was absolutely normal. The CT was not showing any mass lesion per se or any pancreatic, portal vein or splenic vein infiltration or involvement, even with that much bulkiness in the head, if it would have been malignancy, there would have been a chance that the pancreatic head would have got involved. And patient's age was only 31. I'm not denying that patient with 31 age cannot have a pancreatic head malignancy or mass, but then it was not there. And one more thing, patient didn't have any pain. Pancreatic head mass or a malignancy should at least give a dull aching chronic type of pain or a backache.
In stage of alcohol-related pancreatitis is almost like cirrhosis, no? Cirrhotic pancreas, we call it. So pain almost disappears in these patients. So just wondering whether that is one, and how dilated was the CBD?
CBD was around 1.2 centimeter.
It's surprising. It's an inflammatory mass then, basically.
Yes, yes, it's what an inflammatory mass.
In fact,
Okay,
I
Manu,
must
sir.
tell you that
Yeah.
the impression of US done at AIG was also inflammatory. I exactly don't remember whether the FNAC was done there.
No, no, every time it was a duodenal biopsy which was taken. US FNA from head mass was not taken because it was
I
all
think there was
inflammatory.
no space. There was some technical problem. Saurabh can answer that.
You see, by and large, in the Indian context, when we are looking at patients, unless I see a
Saurabh can't
distinct,
hear you.
see, by and large, in the Indian context, when we are looking at these patients, we see a lot of pancreatitis patients with suspected mass. If there is something visibly hypoechoic or appearing like mass, then we feel the high pretest probability of potentially having cancer in the patient. Now, when definitely does add to the cost a little bit, and patients are always a little wary of it. So when I could just see cystic lesions, calcifications, like absolutely nothing which was hypoechoic or mass forming, plus the location to be able to get a good, you could still get a sample, but then when it's purely looking inflammatory, we don't feel the need to put a needle in these patients necessarily. I mean, correct me if I'm wrong, if anybody else has different thoughts, but that's how we take it.
So
Yes, if it's
one of the very much important aspect by which we can differentiate a malignancy between mass forming pancreatitis is the vessel involvement. Malignancy versus groove pancreatitis or a mass forming inflammation is the vessel involvement. Gastroduodenal artery, the portal vein, they seldom or rarely get completely impinged or infiltrated with the inflammatory head mass. They might get a thrombus, portal vein might get a thrombus, collaterals might come up. But pancreatic ductal adenocarcinoma, the way it infiltrates vessel, that doesn't happen in the inflammatory head mass of chronic or
And his
groove
illness
pancreatitis.
started for last 6 years. He started in 2016 with gastric outlet obstruction and underwent balloon dilation with us also. So that time also he had gastric outlet obstruction.
One episode, yeah.
Yeah.
I would go, Dr. Mukewar, I would go more in favor of acute and chronic for the simple reason, as rightly pointed out, groove has two classical features, pain, GOO, and localized to the groove or the head in the maximum.
Yeah.
Calcification more distally, though I would have been happier with an MR also reconstructed. Calcification in the distal area is very, very unusual in a groove pancreatitis.
So, sir, the calcification were limited only to head in this patient. They were not in the body or tail. Body and tail were
Not in the
absolutely
body
atrophic.
and tail.
Yeah, they were
But
atrophic.
even then, the extent of calcification is against
Yeah.
groove.
Yes, yes.
Mostly parenchymal. Now, were these ductal or were they parenchymal?
It were parenchymal, sir. These were parenchymal, and that punctate
Okay.
calcification in parenchyma actually can go in a segmental variant of groove, segmental variant. But then the extent of calcification was too high to call it groove. That is one
Correct.
point against
So
it. That's what
I go with your assessment rightly that it's an acute and chronic. The repeated continuous alcohol probably triggered the episodes.
Yeah. The only confusing part was the cystic lesions which we could see, or probably we had groove in our mind. That's why we were looking for those cysts in the CT.
Yeah, but intrapancreatic cyst is not unusual. So I won't put it against our diagnosis.
Yeah. Yes, sir. Thank you.
Yeah.
And the surprising thing is, as you rightly said, 75% of CP to 80 present with pain and 90 to 95 have pain in the course of the illness. I think this man, other than 2016, when he would have had pain, never had pain, which is also very unusual.
Yes, sir. Yes.
What is the
were
mechanism of pain, sir? Mechanism
Huh?
of pain? Mechanism of pain?
Mechanism of pain is multifactorial, Jayanti. In this, since there are no intraductal stones, so ductal hypertension is gone. So it leaves neural, ischemic, parenchymal, and nociception. Nociceptors now are coming more and more into, the reckoning as we probably go into the pathogenesis.
Sir, just one query from my side. This patient had a necrosectomy in 2016, and right now the body and tail are absolutely not there. In the CT, we could not appreciate the body and tail. So can that be the reason why he doesn't have any pain or ductal hypertension? Because the pancreas is not there. Literally, he doesn't have.
There is a theory by Aman. Aman was one of the big workers of pancreatitis in 1999. He put that as Jayanti said, pancreatic burnout. Generally, in alcoholics, it starts at 10 years, where your pain totally disappears. Now, this man, it has started in 6 years. So, is his burnout a little earlier than what we normally see? That is the only thing.
Okay.
Well-known theory of Aman's pancreatic burnout. People agree, people don't agree, but it is according to him, at 10 years, you start getting a burnout. This man has got it earlier. Another explanation.
How was the liver?
Yeah, so Sudhir has an
I think the
online
liver
question.
except dilated CBD, nothing else was there, I think. No
Liver
secondary
was
biliary cirrhosis.
No cirrhosis, ma'am. Yeah.
Okay.
Yes, yes.
So Sudhir has an online question. Why earlier necrosectomy was done in Groove's pancreatitis?
No. So it was to 2016 necrosectomy was done. That time it was not that time it was not a group pancreatitis. It was a classic alcohol-related necrotizing pancreatitis. Patient had walled-off necrosis
With
with
probably
sepsis.
a walled-off necrosis.
Yeah, that was the reason why necrosectomy was done in 2016.
So
Yeah.
extending on what you were saying right now, and how you said that after the necrosectomy, the body and tail were basically not present.
Not present, not
So,
atrophic, grossly atrophic.
atrophic.
We
So
didn't
in
see
that
any.
case, I think saying that the disease is limited to the head when the body
Yeah,
has
yeah.
almost already been removed might not be a very appropriate thing to say. I mean, we don't have the body and complete body and tail to say that they were not involved before the necrosectomy.
But probably,
Yeah.
probably.
So maybe
Yeah.
we're just saying grooves in this.
Yeah.
case. Then the second question, Dhananjay Kane is saying, what you did was right. With gastric outlet obstruction and biliary stricture, you might be justified in doing pylorus preserving pancreatic or duodenectomy so that the diseased part is out. So I think that's
No, I
a
don't
comment.
believe that. No. Yeah, so treatment of choice for a groove pancreatitis not responding to any medical treatment. Classic groove is pancreatic or duodenectomy. I agree to that, but in this patient, without any pain, resecting that much head, I really don't know. I mean, we have to just treat what the symptoms are. The best palliation or best way the symptoms can be treated was a gastrojejunostomy and a biliary drainage in this case. Thank you.
So very good cases by Yogesh. So I would like to invite Dr. Saurabh Mukewar for a second case, the failed ERCP with what next.
Small request to the panelists, chairperson, we are unable to hear you, so maybe a little louder in the mic. Saurabh, little louder in the mic.
Oh, yes, sir. Hope this is okay.
Yeah.
Okay, so I'll be talking about patients with failed ERP rather than ERCP, which is endoscopic retrograde pancreatography and stenting, and what would you do next? So this is my first case is a 35-year-old gentleman with a known case of chronic pancreatitis in 6 months. He had recurrent pain 6 weeks prior to presentation, and the etiology of chronic pancreatitis was chronic alcohol consumption. A CT scan and an MRCP were obtained, and as you see on the MRI, the entire pancreatic duct is sort of dilated, especially in the head neck region, with relatively less dilation in the body tail region. And these were the outside scans, hence we don't have a nice video like showed the case before. So ERCP was planned with the idea of stenting the pancreatic duct, given the dilated duct and persistent pain. And as you can see, multiple attempts. I'm going to pause here for a second. So that was an illustration of the ERCP, and the problem was there was a stone in the head of pancreas preventing passage of the guide wire. So multiple attempts were made by 2 operators, and then we could not gain access to the proximal duct. So in this case, we decided to approach this with endoscopic ultrasound to place a stent in the pancreatic duct. The idea being you want to drain the pancreatic duct in a parallel route to reduce the ductal hypertension and help with the pain. Certainly not a definitive therapy like ERCP is not, but the idea is just to drain the pancreatic duct in this particular case. And here we are looking at the pancreatic duct. Now we are looking at it across the duodenal bulb. Now what you can see here, this is across the duodenal bulb. We find the pancreatic duct, which is dilated to about 9 millimeters in this case. As you can see, we can visualize the pancreatic duct being dilated, and I am advancing a guide wire from the duodenal bulb here. And then we use a cystotome, as you have seen in prior interventional EUS videos. This is used to create a fistula tract between the duodenal bulb and the pancreatic duct in the head neck region. This does require some maneuvering, and in this particular case, eventually a 5 French stent is being deployed across. This is, now you can see in the bottom left of the screen that the 5 French stent is being deployed, and there you see. So this was my first case, and this was a pancreatico-bulbostomy, and recovery was uneventful. The patient was discharged the following day. He's asymptomatic for the last 3 months, awaiting sort of more definitive treatment for the chronic pancreatitis of the stones. Next patient is a 26-year-old female. She was PNC 3 months out. History of recurrent epigastric pain since 1 year. An outside ultrasound showed chronic pancreatitis. And a CT scan performed at center, we could see there was calcification in the head. I'll play that again. So you see the duct is dilated, and then there's calcification in the head region with the stone obstructing and this pancreatic duct in the head. Again, since similar to prior case, ERCP was attempted, we could gain access to the bile duct here, but then cannulation of the pancreatic duct was not possible. So biliary sphincterotomy was done, and then attempts were again made. But despite multiple attempts using various devices, sphincterotome, cannulas, different guide wires, we just could not advance it and gain access to the duct. Even the minor papilla was cannulated. You see the contrast line there from the previous injection from major papilla. So again, like I showed you in the previous case, here we now used EUS here. We are looking at the pancreatic duct across the duodenal bulb. You see the pancreatic duct is diffusely dilated. And this is the more proximal part of the duct, what you see here, black and white. So now again, we are visualizing this like in the previous case. This was about 10 millimeters. And I tend to also measure the distance between the duodenal wall and the pancreatic duct. Now in this case, you see again, similar to the previous case, the needle is advanced. Now some challenges that we encounter because the scope position is very taut. So you don't really get straight angles. So it requires some maneuvering, and then ultimately, like the previous case, we got contrast. It's a dilated duct, cystotome to create a fistula. and a stent is deployed now straight across the duodenal bulb. Again, this patient also recovered uneventfully and was discharged the following day. We did have a telephonic follow-up. Patient has been asymptomatic for 5 months. Patient underwent stent removal outside locally, and pancreatogram is suspicious for the stone in the pancreatic duct. And as you see on the calcifications, intraductal seen on the CT scan, as well as on the fluoroscopy views, there was a stone, but we went proximal to the stone to dilate, to drain the duct. So EUS-guided drainage across the gastric or the duodenal wall. So this is the first reports were of EUS-guided pancreaticogastrostomy. In our prior meetings, we have shown cases of pancreaticogastrostomy. We did. Those were primarily for pancreatic ascites, where we went across the stomach into the pancreatic duct. And this was the first report, and this is way back in about 2000 or so, about 20 years ago. And about 350 cases have been reported so far in literature. When we are looking at drainage with the help of endoscopic ultrasound of the pancreatic duct, there are several techniques and ways. You could either be anterograde, which is going across the stomach, and then you're going towards the papilla. So transpapillary, which is from the stomach through the pancreas across the papilla. And then you could go anterograde transgastric, where the stent ends before the papilla. Or you can go anterograde transenteric. I've never done this case before, but this is through the bulb going towards the papilla. Retrograde transpapillary, which is rendezvous. Basically, you get a guide wire through the papilla and then place a stent. Retrograde transgastric, which is from the stomach going towards the tail. And retrograde transenteric, which is what our cases were, and we went retrograde from the duodenal bulb. So if you look at indications, when you basically are looking at an ERCP as an indication with a dilated pancreatic duct, causing ductal hypotension, a stricture in pancreatic duct, ductal disruption or pancreatic fistulas, and then it fails either due to inaccessible major and minor papilla by ERCP, or inability to cannulate, or inaccessible pancreatico-enterostomy site, which are post-surgical patients who have stricture at the site. Some things worthy of considering whether a patient is an operative candidate, and you want to be judicious and be careful as you're doing these procedures. Contraindications include invisible duct, non-dilated duct, which are obvious contraindications, multifocal strictures, long distance from the GI tract wall to the pancreatic duct, intervening large vessels, which are obvious contraindication, and bleeding risk because you are creating a fistula. So to share our experience, we have done about 17 patients thus far in which we have placed stents from the duodenum or stomach into the pancreatic duct. The average age was 40. The reason for EUS-guided drainage was essentially failed ERP. The average distance that we've had was 8 millimeters on an average, ranging from 5 to 10 millimeters. The pancreatic duct size on an average was 6.6 millimeters. Non-dilated, we've had some cases where it was less than 3 millimeters, the smallest being 1.4, and the largest diameter being 16 millimeters. Technical success in those we felt worthy of doing the stent was 100%, but there were a couple of maybe 2-3 other patients where the duct was absolutely non-dilated, or there were intervening vessels in which we planned for it but could not do it for those reasons. Adverse event rate, we had 3 patients with issues. 1 had post-ERCP pancreatitis, but none of the other 16 have had that. Stent migration, actually maybe a couple of patients had stent migration, as the stents don't tend to anchor very well. Self-limited bleeding, actually the previous patient, I think we missed from the video a little bit, she had some bleeding and oozing from the site, which was self-limited. So if you see our approach, we have had transgastric as the most common approach, which we have shared in the previous presentations. The reason to show this was just a different flavor. These were transduodenal stents that we placed today. And there's one which is transgastric and transcystic in the pancreatic duct. Anterograde is sort of what we did mostly as we did a transgastric stenting. Retrograde was about 41%, and we did one case which was through the stomach and pancreatic duct and across the papilla. Uh, this is a series out of India from the Global Hospital in Mumbai, from the BIDS with Dr. Mahadev. They've been doing this, I suppose, for a while. They've had about 21 cases of transmural pancreatic drainage, which about 88% success rate. And this is a large series of patients compiled together with various series here. You can see most of the series are not very large, maybe 10 to 30, 40 in one series. Technical success, again, was highly variable from 40% up to 100%, with reasonable clinical success, about 70, 80% or so. A lot of them have experienced some issues, pancreatitis, pseudocyst, pain, and so forth. And the series goes on here. So overall, if you see from literature, technical success is about 90%, clinical success of 87%, and complications, or I wouldn't say complications necessarily, but adverse events, which could oftentimes be self-limited, about 10 to 12%. So I'm sure there'll be some critical questions. I'm happy to take questions. Thank you.
First of all, I would like to congratulate you for your skills and success. It's a very good series you have presented.
Thank
You have
you.
presented the review of literature discussed quite well. We can now take questions from our national faculty as well as local.
What is the difference between, is the transgastric easy to do than transbulbar?
Actually, we started with transgastric, most of our series. And then lately I've done the transbulbar ones. The difference lies in the scope position is easier in transgastric, but more difficult in transbulbar. The distance to traverse is more or less similar, sometimes feels a little more in transbulbar. So that's one thing, but it's also a reasonably stable position. Stent advancement is more difficult, relatively can be challenging sometimes in transgastric, but much easier in transbulbar because the axis is absolutely straight. Versus transgastric, you go across the stomach and then it sort of curves around into the pancreas. The problem lies in transgastric is when you have a very tortuous pancreatic duct with a lot of tortuosity, where your guide wire movement and manipulation becomes more challenging and the stent advancement. But in pancreatico-bulbostomy, it's a fairly straight axis. So it's relatively easier. So I feel maybe I'll move more towards bulbostomies. But yes, I think if you want to, down the road, get an axis with, say, pancreatoscopy, and if you want to do laser, of course, ESWL is obviously a thing to do, but here I'm talking about endoscopic approach. In this case, if you want to do pancreatoscopy, then a transgastric approach is probably more suitable than transbulbar, because from transbulbar, you cannot put the pancreatoscope, you can't take a U-turn with the pancreatoscope.
What is the long-term follow-up of these patients in the literature? Because there are very few, but what do they require? What is the long-term follow-up?
So I think long-term follow-up sort of depends on the underlying condition causing this. Now, if you are looking at stones in the head of pancreas, and if you're performing definitive therapy in these patients, then certainly, sometimes you have access, then you can do rendezvous, go through standard route, ESWL, pancreatoscopy are options performed. If you have a stricture, then again, you place a stent initially, then you gain access again, and then dilate that stricture off, because surgical option is the alternative. I think it all sort of depends on these patients, but it's essentially perhaps a stopgap arrangement for draining the pancreatic duct at that moment in time. Certainly, it can be used for long-term therapy once you have an axis, which is an alternate axis, but certainly can be used, yes.
When would you consider surgery in such patients with large pancreatic duct? That's one question. And the second one is, how difficult or easy it is to position the scope in the gap during the bulb? Thought with the stomach, it's easier to position your scope. Whereas in the bulb, I thought maybe it slips more often.
Right. So it is a taut position, but it's a stable position, but does require some maneuvering to position the scope appropriately there. Now, That's the scope position. And as far as the surgery is concerned, actually, the second patient I had advised, maybe you can just go ahead with ESWL, but this patient was brother of my fellow with me. And he said, no, sir, just I want you to put the stent in. We'll figure it out later. But I said, okay. By and large, we were more confident after our 17 cases that most of these patients we have not had any major problem or issue in. Again, we have not done 500, but after 15, 17 cases, we felt reasonably confident and we did not see any major vessels, or we were pretty confident in doing it successfully without causing a problem. So that's why we felt it's okay to do. And the first case, yes, the patient was not at that point willing or ready for surgery. And certainly, as we approach these patients, all chronic pancreatitis with ductal obstruction, we by and large put stents in, the idea being to assess if that improves your pain before any surgical intervention is considered. So that was the other explanation in some ways, to drain the duct, make sure the pain goes away, then you can proceed with surgical intervention.
Well, I would consider ESWL somewhere
Yes,
in
yes.
between.
No, absolutely. I think not to discount it. What I mean is surgical or
Yeah.
ESWL, certainly, yes. Yes.
Because the first case you said a stone was obstructing. So,
Yes.
we know ESWL is a limited facility. So, if the stone was obstructing, maybe after an ESWL, we could have passed a guide wire, but that's only hypothesizing. And Jayanti, duodenum is always more stable for an EUS man. They are happier in the duodenum than from the stomach. Is it? Am I right?
Yes, happier and depending on the case, I suppose.
Yeah.
But yes, transgastric, sometimes it looks beautiful and it's so straight. But yes, yes, with US, advancing the stent, as I said, is much straighter from duodenum versus across the stomach, yes.
So, sir, I have one question. Sort of this bulboduodenostomy procedure which you are doing, how much near or far the gastroduodenal artery is when you are doing this procedure?
Right.
Because that is something which we ligate during surgery, and it lies exactly at the area where we lift the duodenum near the head of pancreas. And what I could see, the stent was very much near. That is what my appreciation is looking at the video. So on endoscopic ultrasound, how far it was while your stent was going in?
I mean,
Or
with
how near
US,
it
of
was?
course, yeah, without US, of course, you can visualize vascular structures clearly, and you want to avoid them. Now, it must have been in the vicinity, I don't recall exactly in these cases, but we find an avascular window with the scope positioning being torqued in the right way. You know, if you find it, it's safe, you can go ahead and do it. Yeah.
One question is like that, in chronic pancreatitis, we have to ask the patient for stent exchange, maybe after every 3 to 6 months. The same protocol we have to follow here. And second question, if the same protocol we have to follow here, so every time we can use the same track for this stent, or we have to create every time a new fistula for stent placement?
See, I think what is achieved is a fistula, which after a 4-week period is, I would imagine, epithelialized, that even if the stent were to fall out, there is a tract which is formed and epithelialized. Now, whether you need to keep performing stent exchanges is a matter of question and debate, because you could put stents again to maintain the integrity. The question is whether it's spontaneous closure of the tract which will lead to recurrence of symptoms. Now, that we don't know, because both have a relatively shorter follow-up and are awaiting definitive plans. Therefore, but from other experiences from US guided creation of such fistulas, you can remove the stents and, you know, the fistulas may close over time. So therefore, ideally, you may want to exchange the stents if somebody's not planning to undergo definitive therapy, say ESWL or surgery, and you just want to do something. You could just keep exchanging them, or maybe, you know, just leave something in there for 6 months. The tract is so well formed that everything keeps flowing around it. You don't need to do anything.
In fact, I want to share the experience of one of our first patients. I think it's more than a year.
Yes.
We removed the stent and he's still asymptomatic.
Yeah.
So probably there is a fistula formation which leads to drainage of the pancreatic juice through that fistula. Manu, what is your experience of these cases?
It needs considerable expertise. We ask only, I don't do endosono, Shrikant. We ask only our experts, the seniors in the endosono group. And as Saurabh has rightly said, the success rate is around 92%. We have had complications. Pancreatitis, especially, and sometimes if you overestimate, the distance is a little difficult, then it becomes a little technically challenged. There may be a small leak there. So pancreatitis is the commonest. Success rate is around 92. We only ask our seniors to do it. It needs considerable expertise to do a good job and avoid problems.
Thank you.
Thank you, Saurabh. Now I would like to call upon Dr. Shrikant Mukewar, sir. Yeah, regarding ERCP.
Madam, can you hear us?
Yeah, we can hear you.
Okay.
Manu, can you hear?
Yeah.
Okay.
Yeah. I would like to call upon Dr. Shrikant Mukewar, sir, for ERCP in pediatric age group. Pediatric pancreatitis is definitely a challenging job, and doing some technical issues and following up of those patients is also equally important, because one ERCP is not going to solve the problem. And this is not most of the times a alcoholic pancreatitis. We deal with lot of hereditary pancreatitis, and it would be interesting how Dr. Shrikant Mukewar, sir, approaches this case. Over to you, sir.
This was a story of a young girl who presented to us in 2016. That was nearly about 6 years back, when she was 16 years old, and now she has become adult. But she has taught us what is the natural history of a pancreatic patient when it starts in the childhood. How does it develop? And you will be amazing to see the development. So she had presented in 2016 with recurrent episodes of pain, which was there for last 2 years. Every time the lipase was elevated, the etiological workup did not reveal gallstones, calcium, the parathormone, the thyroid, the triglycerides, ANA, IgG4 was negative. There was no history of any drugs, no history of trauma, no family history of pancreatitis. So this was the first ERCP which was done with us in October 2016. She had an MRCP probably, but the films have been misplaced since it was 6 years, and our record also we couldn't trace it. But the ERCP revealed that you can see after cannulation of the major papilla, you can see a duct which is more or less normal, except for slight dilatation in the tail of pancreas, which I have marked with this circle. So the normal PD was done from the head to tail, except for slightly dilatation in the tail. Empirically, pancreatic sphincterotomy was undertaken because she had pain. There was no thought that there was no need of pancreatic stenting because the duct was normal. Then she was well for a period of 3.5 years, 3.5 years. Symptoms recurred after 3.5 years when she had an ERCP done outside. And that time the cannulation through the minor papilla was done. The pancreatogram suggested dilated PD but no stone, and the stent was placed, and the diagnosis was done as a pancreatic divisum with both dorsal and ventral ducts dilated with communication in the head. So probably she had an incomplete divisum, as a result of which there was communication of ventral and dorsal duct. minor papillary sphincterotomy undertaken. Then the stent was also removed in January, but the pancreatogram was not obtained. So this was second ERCP, which was after a period of 3.5 years, somewhere in 2020. She had again come to us in after a period of a year, that was in October 2020, and with the recurrence of pain. And as you can see here, you have a dilated PD in the head. Then there was a stone in the head of the pancreas, as seen in the third picture. And they were intraductal, I mean the dilated duct, intraductal calculi. So we had to do ERCP. Third time, the pancreatic divisum was there. There was a dilated PD, and you have a pointer. There was a head in the pancreatic. इससे दिखा सकते हैं? Cursor. Okay. So there was, if you can see, there was a stone. This was the stone in the head of the pancreas. The pancreatic duct was grossly dilated with dilated side branches. So a 10.7 centimeter straight plastic stent was placed, and the patient was advised to undergo ESWL or a PD clearance with laser lithotripsy. So she had come to us after 3 to 4 months, that was in 12 December 21, about last year. And then we removed the stent, and this time this is the video. You can see that the stent was removed. The pancreatoscope was inserted through the ampulla, and actually, where is Saurabh? You were supposed to. In fact, Saurabh is supposed to comment on this, but can see the pancreatic stone, white stone. This was blasted with the laser, as you can see here. The PD stone was blasted with the laser. Saurabh is here, please.
No, no, it's okay. So yeah, this patient, we performed pancreatoscopy, and you see this is a digital spy scope which goes in the bile duct. Here we are advancing in the pancreatic duct. So this patient had fairly limited stone burden in the head region, and the remainder of the duct was fine. So therefore, we felt this patient could be adequately managed with chronic with pancreatoscopy. And what we have, what I showed you in the video before, you could see the pancreatoscope with all the stones, and those with laser, we broke the stones down in smaller pieces, and they were removed. So here the stent is placed. We use a nice big 10 French stent here, and excuse me, sorry. Okay. So I think beyond this, it's pretty standard. Yeah.
She had, after this laser lithotripsy, she had another minor episode of pancreatitis in February 2022, which was managed outside. The ultrasound showed the migrated stent, so possibly whatever stent was put after lithotripsy had migrated. She had again undergone ERCP which showed that this time the stent was not there, but then she had a stricture in between the body and tail area. This was the area where you can see that there is a narrowing. So she has developed a focal stricture there. Dilatation of the stricture was done with the hurricane balloon, and a 7 French PD stent was placed. Follow-up was done, had 2 episodes of mild pain resolved with tramadol, not needed hospitalization. We wanted that the stricture should be dilated completely, so another ERCP was done and a 10 French stent was placed in pancreatic duct. And as you can see here, the duct has reasonably dilated. So, summarizing the various procedures she had done, October 2016, she had focal dilatation of PD in tail. Probably the partial divisum was there, which could not be picked up. October 2019, there was a divisum, dilated PD, both dorsal and ventral. 21, she had stone, which was blasted with the laser lithotripsy. Then she had a PD stricture, the 7 French stent and 10 French stent was put. She had a recent MRCP, which shows a reasonably dilated PD, except for some amount of narrowing here, but she is presently asymptomatic. So last hospital visit is that she is asymptomatic. Of course, because of her age, not immediately willing for surgery also, and she is relieved with so many efforts. The second patient was a 7-year-old boy with 17 kg of weight, recurrent history of pain for 2 years, worsened for 2 weeks, outside USG suggestive of chronic pancreatitis. The etiological workup, USG no gallstones, calcium normal, triglyceride normal, no family history, no trauma. You can see the CT scan with us showed again a dilated duct. You can see here a grossly dilated PD. Atrophic pancreas with parenchymal calcification. We did ERCP. Video. It's always a challenging to do an ERCP in a 6-year-old boy because you don't get space in the duodenum. But luckily, we could go into the PD easily. The PD was dilated, and once we do the pancreatic sphincterotomy, a gush of pancreatic fluid, which was under tremendous pressure, came with lot of pancreatic juice, and the stenting was undertaken. And immediately within hours, the pain of the patient subsided. The problems in pediatric age group is abdominal pain may not be expressed properly if the child is young, less than 4 to 5 years. Adult scope cannot be used, and I am not aware that the pediatric endoscope ERCP scope is available. To my knowledge, pediatric ERCP scope is not available, and one has to do it with the adult scope. Maybe Manu can throw a light on it. Adult scope cannot be used if the child is less than a year or less than 10 kg. There is less space in the duodenum, general anesthesia, and you have to be little gentle when you tackle the papilla. I'll just give you a review of literature of the first observation international multicentric study in of the risk factors associated with pediatric acute recurrent and chronic pancreatitis, the INSPIRE study, which was published in JAMA 2017. This was a multicentric study, observation study, which compiled many patients, the largest probably, and the findings are one-third of the patients with acute pancreatitis have recurrent symptoms. By definition, acute recurrent pancreatitis is more than 2 episodes of pancreatitis with normalization of pancreatic enzymes and abdominal pain in between with the gap of 1 month. So for defining chronic, one has to have abdominal pain with imaging evidence of chronic pancreatitis, exocrine insufficiency with imaging evidence, or endocrine insufficiency with imaging evidence. Either one of these will define as chronic pancreatitis, and between acute recurrent pancreatitis 155 and chronic pancreatitis 146, the age and the sex ratio was more or less same in this. The Hispanics were more likely to get acute recurrent pancreatitis than chronic pancreatitis. The genetic cause, which is the most important cause of chronic pancreatitis, was seen in 48% of these ARPs, while 73%. So 3 out of 4 patients with pediatric pancreatitis would have a genetic cause. Obstructive cause, there was no significant difference. The toxic metabolic cause was more with acute recurrent pancreatitis. The disease burden was more with chronic pancreatitis. Obstructive cause, 3 things are there. One is pancreatic division. Pancreatic division means, for the non-gastroenterologist, we have 2 ducts, major duct opening in the major papilla and the minor duct opening in the minor papilla. So if this gets reversed, which is called as a dominant dorsal duct, that is a pancreatic division. Abnormal union of pancreatic duct with the bile duct are the long common channel, which leads to reflux of biliary content into the pancreas and sphincter of Oddi dysfunction. So genetic causes are common. Second are obstructive causes. Third are autoimmune causes. And fourth are toxic and metabolic risk factors like alcohol, which are more common in adults, not so common in pediatric age group. But yesterday only I have seen an 18-year-old boy with full-fledged chronic pancreatitis. He started drinking alcohol, toddy, at the age of 9 years. Natural history of these patients is not studied systematically. Most of the data of the adults support that the progression occurs from ARP to acute recurrent pancreatitis to chronic. It is believed that RAP is the precursor of chronic pancreatitis and both are the same disease continuum. Probably the first case has PRSS1 mutation in spite of divism, because these cases probably tend to develop a chronic pancreatitis, a severe form of chronic pancreatitis, and the progression is more. Of course, we don't have much experience about the genes because we are not doing it routinely, and the patients are also reluctant to get it done. But in fact, in this INSPIRE study also, very less number of patients have had a genetic study because it was on the discretion of clinicians. The management is step-up approach, analgesics, non-opioid followed by opioid. pancreatic enzymes uncoated, endoscopic treatment, sphincterotomy, stenting and stone removal, and surgery probably the last option. Thank you.
Okay, sir. In pediatric pancreatitis, more or less, as you said, genetic is discredited to the clinicians. What I feel is we should press and impress on the patient. Now it is available 10,000
Yeah.
rupees. You can do it very well.
Yeah,
There
yeah,
are two
yeah.
reasons for it. One, whatever amount of the duct is dilated, I have seen many patients. Whatever amount of the stones may be, if there is asymptomatic, do not touch. And if you have genetic mutations which are present as SPINIC1 or CFTR or PRSS11, most of the times the person will go for ERCP n number of times in her life or his life.
Yeah.
So why to expose that child to so much radiation persistently if he is asymptomatic? So from our point of view, what we more or less as a pediatric gastroenterologist follow, try to be as less invasive as possible and don't try to do too much maneuvers, because even if whatever maneuver dilatations you are doing, it is going to recur. So I would suggest most of the patients, if they are affording ERCP, there are two advantages. One, in that patient, you know what is the recurrence. And second, in the next pregnancy, if the mother is planning or the father is planning, 6 years, 7 years old children are there, you can tell them the chances of inheritance. See, 25%
of?
inheritance again in the next pregnancy. So it is become very common. If
Yeah.
you have that specific mutation, you can counsel the family. So for pediatrician, as well as for gastroenterologist, as well as for a physician, genetic testing is very useful. Thank you.
Yeah, I totally agree with you. For the asymptomatic patient, we don't touch, definitely. But for symptomatic patient, it has to be done. And she had recurrent episodes of pain. So I think she deserved the procedure. The only argument can be why not surgery. But this has happened over a period of time. We never knew when we did the first procedure that she is going to undergo 6 procedures ahead. And secondly, again, with the first, there was only dilated duct. Secondly, then there was a development of stone. Thirdly, then there was a development of stricture. So all that happened over a period of stage. In fact, if you can find the first pancreatogram, which I'll show you, nobody will say that this is her pancreatogram. This was her pancreatogram, first pancreatogram. So that was in 2016. So this is how it depicts that the natural history of the disease. One can always argue that divism may be the cause, as the division even in the INSPIRE this thing, and in our experience also, if the patient has recurrent symptoms, if the divism is treated, the patient's problem subside. But we have to have a genetic testing also of these patients. Patients' divism per se is also accepted as one of the things. But looking at this, I feel that we should get a genetic testing. In fact, I called the patient tomorrow. She is coming for genetic testing.
Sir, excellent case, sir. My question is for Dr. Vaikar, sir. So in a patient, especially pediatric age group patient, presenting with either a recurrent acute pancreatitis or maybe a chronic pancreatitis. So we more often see patients with recurrent acute pancreatitis in pediatric age group or in the second decade of life, where they come with us with 1 or 2 episodes already have occurred. They have resolved. Now the patient is asymptomatic in between, and the pancreas doesn't show any chronicity or any evidence of chronic pancreatitis, even on the endoscopic ultrasound, which is supposed to be most sensitive. Now, in this case, would you advise genetic testing for every single patient, or only to the patients who seem to have some family history?
Yeah, that's an excellent question. The retrospective analysis of many studies now done, they have found that pancreatic divisum are associated with genetic causes. As sir has rightly said in INSPIRE studies, if you are taking 4 patients, 3 would have a genetic cause. So not for every pancreatitis, but if you are going in a progressive, natural history of progressive, first episode, no one is going to work up. No one is going to ask for genes. But if within a period of 2 years, he has 6 or 4 episodes of pancreatitis requiring interventions, definitely you would ask for genetic studies.
I think we ask Manu Tandan about his experience because you are doing genetic studies at AIG. So we'll have your comments on this.
Two comments, Shrikant. One, we did publish, Jaya was a pediatric gastroenterologist. She actually presented it at DW and GIE. We presented 184 cases, I think 149, if I remember. I was one of the authors writing it, or maybe 150 were chronic pancreatitis. Age group average mean was 13. Success rate was good. Complications were only less than 5%, just like an adult. So it's a practice which is not uncommon. It's not that we do. The second of your questions was we had a very old pediatric scope. The newer models don't have a pediatric scope. We have damaged our old pediatric scope, which was actually a lens viewing one, eyepiece one, and we have no pediatric scope at this given time. We use the adult scope. And third, coming on pancreas divism, we've ourselves published in fact, two papers. Pancreas divism is the commonest congenital anomaly, 9%, 7 to 9%. Incidence of pancreatitis is only 1 out of 100 cases out of them. So there is a two-hit theory, and as Doc has rightly said, it's a genetic background. The first hit is invariably, if it comes in the young age group, is a genetic, whatever all mutations in pancreas are threefold, either the trypsinogen mechanism or the bicarbonate mechanism or the endoplasmic reticulum. Any of these have to be present for a divism to go on to acute, recurrent, and to chronic. And the incidence, Saurabh, I think you must have been in Mayo. Dheeraj Yadav presented a long North American pancreatic study group. 25%, he said, eventually without alcohol or smoking land up in chronic pancreatitis of ARP. So that has been our experience. One, divism needs a genetic background. 25% will lead to chronicity. Pediatric age group, we use the adult scope. The complication rate is not higher. And the commonest indication out of the 185, we presented 150 were chronic pancreatitis. There were a few traumatic and a few acute recurrent with the divism. So this
Manu,
is our
what is the common genes? Which are the common genes associated?
PRSS is the commonest. Pink is less than 10 to in between 10 to 25. We don't see much CFTR, but CFTR, let me tell you, CFTR has got 1500 mutations. We don't see cystic fibrosis much. For us, the commonest is the PRSS group.
So, Manu sir, I have one question for you as well as for Mukewar sir. So, do you believe that early intervention can prevent or can delay the onset of diabetes in patients of chronic pancreatitis?
Yes.
So,
if you ask that, I recently in the pancreatic conference which we had, I presented our data that early ductal, I'm writing the conclusion to you, early ductal intervention will delay the onset of diabetes.
So in the first patient where 6 ERCPs have already been done and the duct is still showing dilatation or the duct is still showing involvement in form of strictures, further ERCPs would be better, or we can directly ask the patient that surgery is the best way forward for her. Now she has already crossed her 30s and she is not yet diabetic at all.
The standard guidelines are our own experience. First, though, if you tell a child's parents that surgery is needed at 14, 13, the first
No, I'm asking the first case, which is now 30s. The first case, the female,
17.
now she is in 30s. She is in her 30s.
Now she is in 30s.
Yeah.
Well, no, she was 16, so she's 22.
17 or 16 in the first, yeah.
So she was 22 years now.
22, 23
Okay.
years. Yeah.
I have the ESG guidelines is very clear that if the attacks of pain interfere with your lifestyle, then as early as 1 year after the first episode of endotherapy, offer surgery if the patient is willing for it.
Okay. Sir, there is also
1
some
year.
surgical literature which says that more than 3 or 4 interventions on endoscopic side,
Yeah,
the
so
results
in
of
1 year it is
surgery.
generally 3 only, 3 to 4 months every time the patient comes.
Okay. Okay.
That is the standard guideline. A lot depends on the makeup of the patient.
Thank you.
Yes, no, yes, no.
Now we move on to the next case. Thank you, Shrikant sir, for.
I think Shrikant, we are missing out on the snacks. We'll compensate when we come to Nagpur.
The next case is a case of.
Those
How
are
many
due
more
with
cases
us.
to go?
Yeah, 2 more cases, ma'am. Stormy case
How
of
many, Jayanti? I don't know.
pancreatitis.
How many more cases?
Two more cases.
Can I?
2 more
10.
cases.
It's already 10:50. I have to catch a flight tomorrow morning.
You
Madam,
then I will
madam,
be
if
there.
you are,
Bhushan has been our student,
yeah,
so he will
Bhushan
take all
is there.
questions also.
Madam, if you are comfortable, you stay. Otherwise, you can go offline. Huh?
No, let her go. If she's got an early morning flight, Jayanti, you go and rest.
Jayanti, madam, you can take
present
rest.
briefly Bhushan.
Yeah, sir. Yeah, sir. Yes.
Thank you. Good night.
Just, yeah. Yes, I'm just going very fastly. It's very honor to present a case in front of my guide, Dr. Manu, sir. Good evening, sir. Yeah. Just gives a mortality of an acute pancreatitis. As we all know that the main concern of an infected pancreatic necrosis, the pancreatitis mortality tune-ups in the measure of 15 to 35%. That's the case. Let me start with this case of 50-year-old male who has developed an acute pancreatitis at the onset of 17/7/2022. The outside CT done, which was suggested an acute edematous pancreatitis with ill-defined collections, was referred to MIDAS on day 3 in view of worsening pain, fever, and breathlessness. There was no comorbidities, and there is no personal or family history of pancreatitis and no history of any medication. So as you see in the first admission, when you referred to an hospital, he was admitted in the ICU in view of an severe SIRS. Patient was conscious oriented, per abdomen was turns and tains tender, and then laboratory test, the CBC, LFTs, RFTs were within normal, procal was normal, and the etiological workers also was normal in the form of calcium and triglyceride. Ultrasound abdomen registry of same as like ill-defined collection, and X-ray chest registry of an left pleural effusion. So he was admitted we found a BSAP score was around 3/5. We inserted the NJ, started an NJ feeding, started an IV fluid as around 3 to 3.5 liters on oxygen and 4 liter. And since the patient was having persistent pain, we also advised the CT since it was done on day 2. We didn't get a complete picture. And just we can see this was a CT which was performed in view of worsening pain, fever, and tenderness. As you can see, the collections are completely ill-defined, more in the lesser curvature, and also the collections are extending into left paracolic gutter also in bilateral way. So he's having completely ill-defined collection, and patient was continuously throwing pain, fever. So this was when he presented. In the second week, he started, just was entering into second week, patient started throwing some fever, and also the procal start elevating. The baseline WBC, which was 6400, has step up to 21,000. The procal was elevated. We step up to antibiotics when the cultures came negative to meropenem. As you can see, the patient, as moving from second week, he started throwing a very high-grade fever in spite of all supportive treatment of nutrition, antibiotics, oxygen support, all the basics, what are the conservative management we managed, we continued throwing, and patient landed in week 2 with severe, what were called maybe an infected collection, considering a high procal level. So as you can see, the counts was continuously stepping up, patient having an oxygen requirement more about 3 to 4 liter was in ICU. We did an USG screening, which is more about the same as was mentioned in the CT scan. So this time in patient was landed in week 2, where patient continued to have fever, tachycardia. There is an ill-defined, very infected peripancreatic collection, and may the patient having in the organ failure in the form of an pleural effusion and having an oxygen requirement. So I really have my chance to ask like what we should do. We should wait, or if we want to drain, what will be the mode of drainage? Yeah, sir. I got Manu, sir. Yeah. But sir, as the paper has come in NEGM where they say that what is a
I agree, but your patient is spiking, a multi-organ probably getting involved.
Yes.
In fact, in an early phase, that may be the only indication now.
Right, sir. Right, sir. So we are
drainage and why PCD? Because left one, the wall is not formed. Saurabh will find it difficult to drain.
yeah, sir.
Maybe
Yeah.
there'll be a lot of debris. It's an acute stage.
Yeah,
And
yeah.
secondly, the paracolic, no way you can reach by the endosono. So it's PCD, maybe two also, one in the lesser sac, one in the left paracolic.
Agree, sir, completely. So just to mention that is an NEGM paper where they found that there is no superiority
Yes.
of an immediate drainage or postponed drainage, rather in the postponed.
I agree.
Yeah, sir. So, but sir, we manage this patient very conservatively, sir. Yeah, we manage this patient conservatively in the hospital. Patient,
you're lucky.
yeah, sir. Patient responded, pain reduced, patient was shifted to ward and discharged on NJ plus oral. Yeah, it was challenging, sir, at that moment at very to put this thing. Patient was having an fluid effusion. We subsequently able to hold on the patient to second week and we managed conservatively. What happened in second admission, patient again came with this thing with a pain, fever and vomiting. There was a persistent feeling of unwellness. Patient always has to, and patient is coming from far away, and patient has some per abdomen epigastric tenderness. This time the WBC count was marginally elevated. Procal was just a normal. Albumin was 2.7. So this patient was not happily managing in the conservative way. We came in week 6. So this was a CT scan on this thing. Now the collection, as sir, you can see it's completely well defined on the lesser curvature, but as you can also see, the collections was in the paracolic gutter, which was also very, we can see communicating or non-communicating has to be very difficult to say. So yes, as you all know that what is the indication of a drainage, as IAP say that if a patient having infected pancreatic necrotizing pancreatitis, better to do mostly after 4 weeks. Or if the patient does not land up in 4 weeks, as sir says, the patient has going a persistent organ failure, or if the patient having a sterile pancreatitis, if it's causing a gastric outlet obstruction, biliary obstruction, or a persistent symptoms, it is maybe an indication of and we should drain the collection. So at that time, sir, what you say, sir, Manu, sir, like we should drain it. What will the mode of drainage, sir?
Well, in this now, first though, I think we would have pushed for drainage definitely first time, but though Pramod Garg's paper from India, 60% will respond to conservative treatment.
Yes, sir.
Similar to the NEJM that you have said.
You're right, sir.
Now, for the paracolic gutter, quickly you went through, if it is considerable, it will not come through endosono.
Right, sir. This is what I'm running through.
You may need a combination of EUS for the lesser sac and PCD for the paracolic.
Absolutely, sir. Absolutely. So we get an options of both endoscopic surgery to the patient. All we know that Penguin trial, Tension trial, MISA trials are all comparing trial. All of the trials, they said the composite endpoints can be made in the form of drain by both the arms, but the length of hospitalization, fistulas are much more lesser in the endoscopic arm as compared to the surgical arm. So yes, sir, as you say, like we went for this this lesser curvature collection by cystogastric lamp placement. It was a pseudocyst. There was hardly any debris. We just put a needle, dilate the tract, and just push a 3 centimeter lamps over it, and we can see a lot of gush of fluid which is coming, as you can see. And also at the same time, we put a left in paracolic gutter. We put a pigtail. So as you say, we manage by endoscopic step up. We put a cystogastric lamps placement and also put a PCD. Patient remain asymptomatic for 48 hours. Patient has no fever. The PCD was draining around 30 ml per day. We continued to do a saline wash. But again, patient had a fever which was really spiking 101 on 5th of like nearly 4 to 5 days after this cystogastro drainage. As you can see, then we do a CT screening. So as you can see, the lesser curvature collections has completely been resolved. But as you all say that the paracolic gutter collections are more about persistently the same. The pigtail is in the C2, which was draining around 20-30 ml of this, but the paracolic gutters were really, it was not draining. So what we did is to upsize the drain. Here Dr. Yogesh Bang, who is a surgeon with us, really helped us for stepping this. A large 28 French surgical drain was inserted under ultrasound guidance and fluoroscopy guidance in our endoscopy suite. We start daily flushing with the saline. The drain output remains around 30 ml per day. Pus. Fever responded. Patient remains afebrile for 48 hours and subsequently patient was discharged. So this was the story on second admission. The patient responded to our subsequent upsizing of stent and patient was discharged. But again, after discharging the patient stayed nearby only to us. had a fever on this third admission and was put on imipenem tigecycline. The patient was started to again having a raised WBC counts, procal was elevated, albumin was on the lower side, and the PCD the surgical drain what was put was draining around 20 ml per day. So this was the CT screening then we did. As you can see, the collections of lesser completed drain, and we can see a large 28 French bore which is completely going through the collection. It is completely crossing the spine and is going crossing it and completely draining it. So and this was a fever chart, sir. After putting this thing, the third admission, patient was throwing such an amount of fever with us, and we are all we are started on imipenem, tigecycline antibiotic. The cultures were more about negative. And here again the question rises, what we should do? We should offer this patient to surgery, or for this lateral collections which is there, should we do such type of sinus tract endoscopic necrosectomy, which is also called as a percutaneous direct endoscopic necrosectomy? What do you think, sir?
Both are options depending on the expertise. If the 28 size you have, so there's a fairly big tract.
Yeah, sir.
You can go in and do a sinus necrosectomy, yes.
Yeah,
but
sir.
I think now that you have used up most of the antibiotics, time to call the surgeon also.
Yes, sir.
Just a comment.
Yes,
Step-up approach is now considered the standard of management of such cases.
Right.
So I agree with what you have done.
Yes, sir.
Now we can take an option depending on your surgeon and the expertise for doing a percutaneous necrosectomy.
Yes, sir. Even Abhiram sir will agree on this thing. Yes, sir. So yes, sir. But we did this thing really in a different way. Since it was a very long cavity, as we can see in fluoroscopy, we try to do a fully covered SEMS placement first, followed by which we can do a necro. As we can see, the scope can enter through a cavity. It was a very long cavity after which we can able to enter the necrosome into the cavity where the necrosome is. We put a guide wire into the cavity. Yes, we can see a guide wire which was kept in the cavity and came back. And it's like a routine SEMS placement. You place an fully almost fully covered esophageal SEMS around 12 centimeter in long and 18 mm in its maximum diameter, as you can see externally. And after, yes, it was a very the track was so long we can able to keep it. We can very carefully seeing fluoroscopically where it is our distal and proximal ends are. Yes, and it was subsequently deployed in a more about this fashion. And then scope was advanced over that fully through the fully covered SEMS. We entered into this more about this paracolic gutter collection, and subsequently we underwent an necrosectomy. Almost 2 sessions of pancreatic this direct endoscopic necrosectomy was performed through a percutaneous esophageal SEMS, as you can see. And this was second session when we entered. The cavity was looking much more cleaner as compared to previous one. We continue to remove using a snare, and sometimes I too also use this Dormia basket. Cavity appears little bit more cleaner. The patient also started improving in terms of fever in our eyes, fever in his ward stay. Yes, there was some bile tinge also. We can say I'd see while doing this necrosectomy. So I really think whether I really have some perforation. I rechecked by using a fluoro again contrast. There was no free flowing into the extravasation of contrast to that cavity into the duodenum. At the same time, yes, this was how we perform a necrosectomy. At the same time, I did an ERCP. Since the patient was after second necrosectomy, I cannulate the pancreatic duct, and I just see the pancreatogram. There was hardly any leak of contrast. The duct was very thin duct. And yes, and while withdrawing, I just prophylactically do a pancreatic small sphincterotomy and just put a 5 French stent. And while coming back from a duodenoscope, I removed that lens which was put earlier. So this is how we manage this patient. So post procedure, I can see the post necrosectomy, the fever has definitely started coming back to a normal. We performed 2 sessions. The SEMS was removed almost on day second. We replaced the drain by replaced that SEMS by using a short 28 French bore along with a small colostomy bag, which was draining hardly 20 to 30 ml per day, and subsequently patient was discharged. This was a little bit review on like a percutaneous endoscopic necrosectomy. Very nice review came in 2022 in Journal of Clinical Medicine, where near about 52 patient was underwent this necrosectomy using a esophageal SEMS. And what you can see that adverse events was ranging around from 0% to 40%, and the most common adverse event was self-limiting intracystic bleed, which was really controlled on his own, and also some 7% to 10% has developed this pancreatic cutaneous fistula, which hardly required any management. Subsequently, over the course of 1 or 2 months, it was healed on his own. Technical success ranging around 100%, clinical success depending upon endpoints ranging around 80%, and the other, sometimes the patient may solely treated by this if the collections are only lateral, or maybe combination as I did in this form. So this is like a short review that the esophageal stents were retained in the body for an average of around 19 days. The average number of pain procedures in this study was in around one patient was around 3 to 4 procedures required for clearance of necrosectomy, and clinical success, as I said, is achieved around 80% of the patient. This study shows that this technique is potentially effective with an acceptable rate of complication and may be implemented with a good clinical results in patients with the pancreatic necrosis. This is another study which was published by our gastroenterologist in Nagpur, like Dr. Bhaware sir, who had a good experience in doing this percutaneous direct endoscopic pancreatic necrosectomy. So on follow-up, patient drain was subsequently removed after 15 days. Patient on telephonic conversion follow-up was doing well, and currently is really awaiting for his pancreatic duct stent removal. So in summary, he is a 48-year-old male who has a moderately severe acute pancreatitis of unknown etiology, has developed an infected peripancreatic fluid collection. There are multiple collection. He underwent a US histogastric clamps placement, followed by the upsizing, followed by PCD and upsizing, followed by this pancreatic direct endoscopic necrosectomy using an esophageal SEMS and ERCP and PD stenting. So this was a completely around 8 to 10 weeks this patient was with us and was subsequently doing well. So in take-home message, this infected pancreatic necrosis is typically associated with a poor, is a prolonged course and carries a poor prognosis with high mortality, tuning up to 20%. The multidisciplinary, minimally invasive step-up approach is really favored over the direct surgical approach. This pancreatic direct endoscopic, percutaneous direct endoscopic necrosectomy has emerged as a very safe, effective, and minimally invasive technique in armamentarium of and management, and should be considered when the conventional drain is in situ by the virtue of its previously percutaneous or surgical intervention. Thank you.
Well, I think it's a wonderful job you people have done, especially have to be commented on placing the esophageal stent. We also do it using a covered stent, but you managed to go right up across the spine, which is a really good technical job.
Yes, sir.
But the approach is right. We prefer the step-up approach. The only thing I may have changed, suppose it was under me, the first time only I may have considered putting in a PCD.
Yes,
otherwise, I think this is right. And if this didn't work, then I think your surgical team had to come in.
Yes, sir.
Yeah, Manu.
So the surgeons may agree, not agree, but I think by and large, a step-up approach is what is now the mode of therapy.
Yeah, Manu, we always follow the step-up approach. The only thing is, if you do the percutaneous drainage, then what happens is the only liquid part comes and the solid necrotic material still remains.
Doesn't come out.
Doesn't come out, and then it probably makes the further endoscopic procedure not that easy. So that is how, because the endoscopic treatment for necrosectomy is a more appropriate method with the introduction of lamps, and these percutaneous methods are now upcoming. So we are not sure of total necrosectomy. The problem is there. So our approach is to delay the process, of course, taking into consideration the patient's safety. And we have seen that patients who had heart rate of 140, 150, tachypnea, SIRS, sepsis, over a period of time, unless they don't deteriorate, probably they settle in. And once the cyst wall is formed, you can go ahead with necrosectomy. So that is our approach, to delay it as far as possible. But I totally agree with you that if there is a sepsis, multi-organ failure, and the patient has shown deterioration, one has to go ahead with necrosectomy percutaneous.
What I
Yes.
see in this case is you had to deal with the retroperitoneal necrosis rather than pancreatic. It was not a necrotizing pancreatitis.
Absolutely,
It
sir.
has been an edematous
Edematous
pancreatitis. The pancreatic fluid collection has resolved with just drainage.
Yeah.
And you are dealing with the retroperitoneal necrosis rather than pancreatic necrosis.
Agree, sir. Completely agree. Yes, sir.
Only one thing to add, Bhushan,
Yes, sir.
I may have done a cologram just to see a colonic communication.
Sir,
Right.
we
Because
always
the
do that,
sepsis-
sir. We always do. I'm Yogesh here, sir. Whenever we are
Ah.
intervening these patients with pigtail or putting a drain across that spine, the 28 French which I pushed across the spine, before such procedures, we always do a CT cologram, sir.
Okay, yeah.
We always
I
do that
recently
as a
did
routine.
because
If we are seeing
that
a
is the
gas,
only other thing. Otherwise, it's a job as well done as you can expect
if
from a
we are
good
seeing a
place.
gas, we always
you, sir. Thank
put
you.
a CT cologram.
Yeah.
So my one question to Bhushan, what makes percutaneous endoscopic necrosectomy different from video-assisted retroperitoneal drainage?
Ward, yeah.
Ward, yeah. What
You,
makes
you,
it different?
You make a 4-5 centimeter incision on the ward. We
Not
do,
necessary, not always.
But
Not
whatever
necessary,
standard
not
teaching
always.
of ward, my knowledge up to ward is like they do
Speak
a 4.
in the mic, Bhushan.
Yeah,
can't
sorry,
hear.
sir. Sorry, sir. So whatever my knowledge, sir is asking like what is difference between ward
Yeah,
and this
ward
thing.
and what you did.
Yeah, sir. So what I knowledge of ward is that they do a 5 centimeter incision in the percutaneous way. So that's the difference that they have. That makes that we do the by simple 28 French bore needle we can able to achieve the same access. But that is my knowledge.
Okay,
of
okay,
Yeah, sir.
okay.
Yeah.
So the same technique which you have done with endoscope can be done with a nephroscope.
Nephroscope also.
Nephroscope.
Yeah.
Nephroscope goes through the trocar which we use during laparoscopy.
Right.
10 to 12 trocar which we can use and we can pass a nephroscope. In fact, I also told Saurabh, if you want, rather than using that long SEMS, I can put a trocar, laparoscopic trocar, and you can put your endoscope through that.
Yeah.
We even tried that in one case, but the maneuvering of scope was a bit difficult through that laparoscopic trocar.
And again, the ward has to be done in OT. We do it in endoscopic suit. That is
you
one-
do
that
it
is one
in
thing.
infected
Yeah,
environment, we do
Yeah.
it in sterile one.
Already infected
Covered
now.
SEMS is more flexible. It is more supple, so it's a little easier.
Yes, sir. Yes, sir.
Okay.
Manu, last case we will bother you because it's an interesting case. I request you to please stay.
Okay.
Yeah,
Thank you,
Akshay,
sir.
you can please continue.
Well,
Good evening, everyone. This is Dr. Akshay, and my case is a bit shorter, but it was just as difficult as the other cases for us. So, without any further ado, I'll just get on with it. And so, a 67-year-old male who previously was diagnosed with diabetes and hypertension was well controlled on medications, presented with recurrent abdominal pain for 2 months. This was increasing in severity. It was non-colicky, there was no vomiting or distension, neither was there any jaundice or pruritus. So the basic investigations revealed an anemia, normocytic normochromic, with a unusually high ESR, and the only problem with his LFTs was a raised alkaline phosphatase, but no jaundice. So the anemia, the raised ESR, and the alkaline phosphatase as the only liver abnormality. There was an ill-defined periportal lesion on the ultrasound, 4 by 3 centimeters. There was minimal IHBRD, and CBD was prominent but was not usually dilated. There was bulky pancreas and a head lesion of 7 centimeters. Still, there is no biliary obstruction, there is no jaundice. So in CCT that was done elsewhere, this shows a large mass. So this was in the Ansenet process. There were loco-regional lymph nodes. Multiple lymph nodes were involved along with the mass. There were also a few portal lymph nodes along with a gallbladder neck thickening. So multiple lymph nodes, gallbladder neck thickening, Ansenet process mass, and loco-regional lymphadenopathy. In fact, all the way to the celiac artery, even the celiac nodes were involved, and they were enlarged in the imaging. in the CECT abdomen, interestingly, also showed some retrocecal and iliopsoas nodes down in the pelvis. They were also very prominent in the same CT. So with this picture, he was referred to us because there was no any easy diagnosis to be established. We did an endoscopic ultrasound and attempted a fine needle biopsy of the mass. So this was a large 4 by 3 centimeter mass in the head of the pancreas, and as you can see, it is not as well defined as a normal ductal adenocarcinoma would have been in the head. It's not as hypoechoic; it's actually a heteroechoic mass. So, and there was only a mild CBD and PD dilatation. The CBD measured only 6 millimeters, absolutely normal. Despite the CBD, as you can see, is disappearing into this mass, but it was not dilated. There was a large portal lymph node from which we also obtained a biopsy. So this is the needle passing into the mass, and we obtained the biopsy of the mass as well as the portal lymph nodes. Now, a different, so this is an odd mass. 95% of the ductal head masses are ductal adenocarcinomas, but odd masses can be either neuroendocrine tumors, they're hyperechoic, they're enhancing on the CT, they're vascular. Cystic pancreatic neoplasms can be diagnosed straight away on EUS. Head masses could include serous adenomas or solid pseudopapillary tumors. But again, these present in the females. This was an elderly male we were dealing with. Chronic pancreatitis needs to have history of recurrent pain, which was not there. It could present with an inflammatory mass. Autoimmune pancreatitis type 2 was a possibility, but pancreas was not exactly diffusely enlarged, and the history was too short. Metastasis was a possibility, and pancreatic tuberculosis. So, any comments or any other differentials the panelists or members in the audience would like to venture?
I think you've listed out the whole series.
Dr. Paranjape sir has advanced a very...
Any lymph node was necrotic in that, because TB, we are seeing more and more of pancreatic TB.
Yes, sir.
Any necrotic lymph node was there?
The CT was done elsewhere, sir, but they did not mention presence of necrosis. They did not
Even on
elaborate on that.
endosono, there were no necrotic nodes.
I would go back one slide to show you the endosono feature of the portal lymph node. It's a completely homogeneous. There is no central hypoechoic component to indicate necrosis. So, yeah. So these are the differentials, and Dr. Paranjape sir has advanced a very interesting differential of syphilis, which I would not know of, or rather not. So syphilis. Okay. Biopsy showed normal ductal structures, atypical cells, hyperchromatic nuclei, and a high nucleocytoplasmic ratio. So ductal structures are intact, and now we have a tumor with multiple sheets of cells. These cells are basophilic nuclei and very scant cytoplasm, and there are sheets of such cells in this. With this atypical cells, we went ahead with the immunohistochemistry because we suspected that there was something amiss here. So in typical ductal adenocarcinoma, there were you will not see you will see ductal proliferation. You will see multiple ducts in the same high power field or low power field, but sheets of atypical structure were there, and so this was really something odd. So, and also the CA99 was normal. Sensitivity of this marker in a pancreas mass more than 2 centimeters is 98%. There were multiple lymph nodes, large head mass, but no biliary obstruction. These were the features which drove us away from the diagnosis of ductal adenocarcinoma, and we deferred any intervention in this case. The immunohistochemistry showed CD20, BCL2, and BCL6 positivity, and turned out to be a diffuse large B-cell lymphoma of non-Hodgkin's type. So pancreatic lymphoma is a very rare pancreatic tumor. Of all primary pancreatic tumors, it comprises only 0.2% of all the tumors. Usually affects the elderly males, like in this case. Primary pancreatic lymphoma can be diagnosed with the criteria of pancreatic mass, mostly in the head, a normal leukocyte count, no liver or spleen involvement, and no superficial or mediastinal lymph nodes. These are called as Dawson criteria, and this is how you diagnose primary pancreatic lymphoma. Secondary involvement of the pancreas due to lymphoproliferative disorders can show you diffuse lymph nodes, hepatosplenomegaly, And the disease is generally due to infiltration from the adjacent lymph nodal mass. Any part of the pancreas can be affected with this. There is no priority or there is no uh, preamble to the head in case of primary. So both come as a hypoechoic mass on ultrasound, and both can be hypoenhancing on CT and can cause confusion. But primary pancreatic lymphoma is larger at presentation, just like this mass, which was 7 centimeters. For a typical garden variety of ductal adenocarcinoma, this would have been straight away borderline resectable or maybe even unresectable if it would have encased a few major vessels by the time it reached this size. Surrounding structures are not compressed despite achieving such a large size by the lymphoma. CA99 is normal. The marker that could differentiate is LDH. LDH is very high in lymphomas, especially primary pancreatic lymphoma. And there is diffuse lymphadenopathy, especially if you see lymphadenopathies, lymph nodes involved below the renal vein in the cross-sectional imaging, you should suspect that a lymphoproliferative disorder is at play. Prognosis depends on the Ki-67 index. In this particular patient, the Ki-67 index at presentation and on immunohistochemistry was 80%. So disease burden was very high. The standard treatment was chemo plus or minus rituximab. And with this, in a short and a small series of only 35 patients, they have reported a 70% complete response rate, and an additional 10% patients had a partial response. But very few have aggressive disease and rapid deterioration. Other than this Italian series of only 35 patients, I could not find any other series on primary pancreatic lymphoma. But rapid worsening can occur in case of chemotherapy-induced tumor lysis syndrome or a primary tumor lysis syndrome or even HLH. Unfortunately, after the diagnosis, our patient landed up in renal failure and started dropping his urine output rapidly, landed up in the ICU with fluid overload and developed encephalopathy, mostly uremic. Since the relatives did not have the finances or the ways to treat him further, they had to take him away, and we could not follow him up further. But mostly he would have succumbed to his renal failure, and mostly a primary tumor lysis syndrome has precipitated in him. So the take-home message is not all pancreatic head masses are ductal adenocarcinomas. Some can be treatable, even if they are unresectable on imaging, they can be treatable. Odd features like no biliary dilatation or large mass with no PD dilatations should be picked up. And a thorough history and investigation and imaging are unsurpassable. When in doubt, always do a biopsy.
Thanks for showing us this very rare case. What was the histopathology from the lymph node?
Lymph node histopathology also showed similar sheets of cells. They were again having scant cytoplasm and large nuclei. They were very hyperchromatic. So typical cells, suspicious of malignancy. Portal lymph nodes showed the same thing.
And IHC was similar? IHC was similar?
IHC was done in both the lymph node as well as the pancreatic mass. Both were similar.
And did the oncologist advise the bone marrow also?
Yes, sir. But the family was not affording. By that time, the patient landed in mostly renal failure, likely because of the tumor lysis. May I ask if Dr. Manu Tandan, sir, since we are considering that the disease in the lymph node as well as the pancreatic mass was the same, is there a possibility that IHC would have been different, or is there a possibility?
I can't hear you well. Is it a possibility?
That IHC would have been different in the lymph nodal mass and the pancreatic mass, or is it
unlikely? In fact, that confirms your thing that you are on the right track. I don't think I have seen a case of primary pancreatic lymphoma. What all we see are infiltrations from adjacent areas and mostly lymph nodes into the pancreas. So it is an unusual case. I was thinking of tuberculosis.
So how sure are we that it's a primary pancreatic lymphoma, not a retropancreatic lymph node? How sure are we that it's not a large retropancreatic lymph node which we have punctured and not a pancreatic, primary pancreatic versus...
Okay, so a large retroperitoneal lymph nodal mass was present, and there were clear-cut borders with the pancreatic mass on the EUS as well. Plus the CT also shows clear margins with this retroperitoneal lymph nodal mass, and there is a definite pancreatic mass. So that's why also if this was a primary lymph nodal disease, then any GI lymphoma, most common site is the stomach, but extra intestinal or extra luminal GI lymphoma involves lymph nodes very rapidly, and it progresses to all the lymph nodes, and the disease burden becomes very high. They also cross over on the other side of the diaphragm.
Above the diaphragm.
Above the diaphragm. So that's why you get superficial lymphadenopathy. This particular tumor fulfilled all the Dawson's criteria that we showed, that there is no hepatosplenomegaly, or rather there was a hepatomegaly, but no liver infiltration or involvement. But we should have taken a liver biopsy on retrospective or second thoughts, because there was increased alkaline phosphatase. Maybe it would have proved or rather ruled out a liver infiltration by the disease, and would have fulfilled the criteria. Then we would have been really able to label this as a pancreatic lymphoma. That's right.
See,
I
Manu,
think
we
your
had
endosono also done under good hands. Saurabh is very good. Will fairly well localize that it is intrapancreatic if you can see pancreatic tissue around it.
Yeah. See, we had presented in our clinical meetings a similar case which presented as mass in the head of the pancreas and turned out to be tubercular. So, in our country, as you said, tuberculosis is one of the common diagnoses. And apart from tuberculosis, adenocarcinoma, lymphoma, neuroendocrine tumor, secondaries, as you listed, autoimmune pancreatitis, all these have to be there in the differential diagnosis. There is a vast list of differential diagnoses when patient presents like this. So I think the clue is in the histopathology, and that is very important that we should take a biopsy and not only FNA, because the biopsy has to go for IC. Many of the times, IC confirmation is required.
Correct. Fully agree. Thank you for those good cases.
Time for a last case, and it should be a very short, I hope.
Thank you everyone from Team Midas. I thank our online chairperson, Dr. Manu Tandan sir, for sparing his time. I also thank Jayanthi ma'am for being there till late. I thank my chairpersons present here, Dr. Abhiram Paranjape sir, Dr. Nikhil Khobragade, Dr. Yogesh sir. Rajvilas could not be here, Dr. Manpreet, for being excellent chairpersons for this evening. I also thank the esteemed audience who have always graced us with large numbers. And I thank my colleagues who have presented excellent cases, Dr. Saurabh, Bhushan, Akshay, of course, Dr. Mukewar sir. And from Team Midas, I say good night to you and welcome you for dinner. Thank you.
Thank you.
Thank you, Manu sir.
All.
Yeah.
I was listening all along. Thank you.
Okay.
Thank you, ma'am.
Right
Thank
off.
you, Manu,
Take
and
care.
thank you, Jayanthi ma'am.
Good night.